Get started.
Great. All right, so welcome to our GW University seminar series hosted by the GW Institute for Brain Health and Dementia, entitled Addressing Dementia Across the Public Health Spectrum. This series brings together researchers to discuss the multitude of issues surrounding the area of cognitive health and dementia. And today I'm excited to introduce our speaker, Dr. Ganesh Babulal, who's I'm especially excited because he's an occupational therapist, so another rehab professional. Dr. Babulal is an assistant professor in the Department of Neurology within Washington University School of Medicine. He's interested in investigating the relationship between cognitive function and mental health and its impact on the daily living activities of those with chronic neurological diseases. His specific research projects include characterizing functional changes in older adults using Alzheimer's disease biomarkers, predicting global decline in aging using neurobehavioral markers, assessing how social forces like discrimination, chronic stress, and racism influence health and well-being among racial and ethnic minorities, and developing and validating effective educational programs to improve and prolong functional outcomes in aging. So the title of his presentation today is Digitizing Driving as a Marker for Preclinical Alzheimer's Disease. So help me welcome Dr. Babulal.
Okay, thank you so much. And it's my absolute pleasure to join you all here today for the Institute for Brain Health and Dementia. I think it's seminar 3 for this year. So I'll start off with my disclosures of interest. Nothing very exciting, just funding from the NIA, NIH mainly, and then some from other organizations, but no stocks, consultancies, or working for big pharma. So I'd like to start out with just sort of setting the landscape as it relates to Alzheimer's disease and related dementia. And most of the talk today will focus on Alzheimer's disease, just given its prevalence, being classified as roughly about 60 to 80% of the cases of dementia overall. So right now here in the United States, we have nearly 6 million older adults that are currently living with the disease. 2/3 of those are women. It is the 6th leading cause of death in the US. But there are also some health disparities as it relates to differential risk for certain groups, particularly for Black and Hispanic Americans. So they're at 1.5 to 2 times the risk compared to non-Hispanic white participants. But also both groups are less likely to receive a diagnosis. And the reason why I brought up sort of those 2 important facts is that by 2050, so in about 3 decades, the US is going to be becoming very diverse. We know that Black and African Americans are expected to increase to about 12%, which is up from 3. Hispanics will increase to about 22%, up from about 8. And Asian Americans will increase to about 9%, up from about 4%. But more importantly, I think the non-Hispanic white population will also decrease from about 78% to about 55%. So when we're thinking about, mid-century here, we're looking at an aging population. And so we do know that those that are 65 and older, that specific band will more than double to about 88 million. And cases of Alzheimer's disease will likely triple to about 14 million. But the economic impact of this specific disease is really going to wreak a significant amount of havoc on, not just the private, but also the public sectors. I've got some projected costs from 2017, which have likely just, increased. And again, this is in the face of no effective treatment that will significantly modify or reduce the prevalence and the incidence of the disease itself. So, now that I've set sort of to better understand some of the risk factors that are associated with Alzheimer's disease, the exposome has been proposed as a very fertile model to better understand the relationship between all of these, context and the individual and function and behavior. And so the exposome, for those of you that may not be aware or understand its definition, it's described as the sum of the internal, which includes biology and genetics, and external exposures, which include the environment. And across the lifespan, we know that influences human health and human behavior. And there's been a burgeoning interest over the recent years to examining brain health and what is healthy aging. So Finch and Kulminski proposed an AD exposome in 2019. It included individual behavior like smoking and exercise, biology, which included genes and glucose, among others, and the environment, which included air pollution and socioeconomic status, whether you live in rural or urban areas, and a few other factors. And so for the rest of the presentation, what I'm going to do is use this as sort of a launch pad to examine the human function in the context of driving and to see if we can predict preclinical Alzheimer's disease. So why driving? I'll come to that in the next slide, but what I want to briefly touch on, because the title encompasses digitizing driving as a digital marker. There's been, over the past recent years, or past decade, I should say, a rapid development in the advancements of sensors, cameras, accelerometers, the shift from 4G to 5G network, telematics, machine learning, and even chat GTP, that's really allowing for high rates of sampling of data. And this itself has also expanded into the biomarker realm, specifically via digital means. And many of us really use a lot of smart devices in our daily life without even batting an eyelash, right? You've got tablets, phones, watches, rings, sensors that are embedded in your clothing that all pick up passively our biorhythm and our function, our movements. And so where I think the rubber meets the road is, longitudinal disease progression requires significant and accurate investment in terms of being able to monitor and to do so reliably, objectively, and continuously over time. Because we really want to better understand, have a personalized baseline for each individual and to better understand how those changes over time, whether they're linked to specific disease states and whether that is increasing the risk for Alzheimer's disease. But on the other side of the coin, we can also notify patients and their family members if something is out of the norm with their longitudinal progression and their neurological health. And so these biomarkers specifically right now can range from saccades, speech, gait, physical activity, heart rate, sleep, and even driving. And today, that latter portion of driving, I'll discuss over the past 10 years, our research to develop a digital marker of driving. So driving is really the ultimate instrumental activity of daily living. So those of us that work in rehabilitation and health, we know the difference between ADLs and IADLs, and it really is a complex IADLs because it requires a dynamic deployment and sustained effort of multiple different systems, including the motor, sensory, cognitive, and affective systems. And as I mentioned previously in the previous slide, that older adults are actually living longer, and they're also logging a lot more miles on the road. Now, we do know that age-related decline impacts one's ability to drive. Older adults are at a much higher risk for injury and mortality in a crash just due to frailty. And based on data from about 3 years ago, this is pre-pandemic, roughly about 20 older adults were killed and 540 were injured in a crash on a daily basis. And so I think those numbers speak for themselves as potentially an intervention that's really required for helping to preserve health and also improve safety. Now, on the other side of that fence, we do know that when an older adult gives up their keys or stops driving, there's an increased rate of driving cessation, increased rate of depression, higher access to institutional care or entrance into long-term care, social isolation, and morbidity. And all of these are sort of the concept. So what I'm going to show you are really a very simple but elegant survival curve that was published many, many years ago. But I'll share this fact for you. If you've got dementia, you're more likely to crash. And so it's a bit of a no-brainer. And what the curve here to the left shows, so we use the clinical dementia rating here at WashU, where it was developed, and it stages an individual on a scale of 0 to 3. If you have a 0, you're considered to be cognitively normal. 0.5 is very mild dementia, 1 is mild, 2 is moderate, 3 is severe. And so what we were able to look at is individuals that are scored as 1 here, as indicated by this green line, they were much faster to receiving a fail rating on a standardized road test. And this is in comparison to really those that are 0. And then you can see those that are with a very mild dementia are right in the middle. So there's this really nice gradation as you shift from cognitive normality to prodromal dementia. Now, autopsy studies in the late 1990s showed that older adults who were killed in a crash actually had the hallmark plaques and tangles that are indicative of Alzheimer's disease at autopsy. And so this really allowed us back in 2011 to start thinking about the relationship between this preclinical stage of the disease. And for those of you that are not familiar with preclinical Alzheimer's disease, it's a long period, so roughly about 15 to 20 years, where an individual remains cognitively normal, but the pathophysiological process of the disease has already started. And we can actually measure these specific biomarkers across multiple different systems. So let's just get through this here. So one way in which we're able to do that is look at beta amyloid and tau within the brain using PET MRI. And we're able to stage actually the concentration, but also the positivity or negativity based on specific cutoffs. Then we're able to also look at those same biomarkers within the cerebrospinal fluid that bathes the brain and then circulates through the CNS. With a lumbar puncture, we're able to capture that, and we're able to get a number of analytes besides just amyloid and tau. And then more recently, which is sort of the holy grail in the field and what many researchers and scientists have been working towards, is the first commercially available blood test for Alzheimer's disease. And we have that here, actually. Randy Bateman and C2N developed that. And it's FDA cleared and available for the general public. But we collect blood and we look at those same analytes within the blood to better understand the disease and really the potency of the biomarkers within them. And so what we do is we collect all of these biomarkers, but we also study driving itself. And so what I'm focused on in terms of our lab is the decline period towards the end of the life as it relates to normal aging and what that looks like for an individual who's driving. So before I get into some of the exciting stuff, I'll give a little bit more context. We followed the cohort here at our Knight Alzheimer's Disease Research Center for quite a few years, actually decades. And this study, we looked at driving cessation over nearly a quarter century. And what we found was when we looked at the clinical dementia rating status, or the CDR status, and their cerebrospinal fluid biomarkers at baseline, we saw that participants that were followed up for 24 years, we looked at to see if they were driving after or at subsequent visits when they came to their annual evaluation. And what it showed was that CDR of 0 had the longest driving time in years, but as the CDR level increased, there was diminishing years remaining and a faster time to driving cessation, as you can see by the green indicating CDR of 1, the red indicating 0.5, and then the blue indicating CDR of 0. And when we looked at this survival analysis with, again, adding in the biomarkers, we were also able to see that those that had more abnormal biomarker levels indicating preclinical Alzheimer's disease were also faster to decline, irrespective of whatever CDR class they were in. So it's showing that there is a signal even in those that are cognitively normal. And so the goal for really our lab and the funding that we've received for quite a few years is really to try to identify those older drivers who are at risk for decline and a crash, but to forecast that decline or when it might occur and intervene before the time of decline. And within this talk, I think with our research studies that we can actually touch on all parts of this. So within our cohort here at WashU, we have been enrolling cognitively normal older adults or older drivers. So they all have a CDR of 0. That means there's no dementia at baseline. And then we enroll them to do a road test annually. So this is the same road test that you likely took to get your driver's license. It starts out in a parking lot and then moves into progressively more complex driving situations like taking unprotected left-hand turns, merging into traffic, regulating speeds from a posted speed limit area to a higher posted speed limit area. And at the end of that road test, the participant is given a score of a pass, a marginal, or a fail rating. And because they're all CDR 0, we very rarely get fails. So if we do, it's likely due to some other comorbid condition. So what we do is we typically package the marginal and the fail rating together and compare that to the pass rating. So in this first study that was published quite a few years ago, what we actually found was those that had more abnormal levels of CSF actually made about 2.5 more errors on the road test compared to those that had normal levels. And when we followed them for 2 years, what we saw was those, again, with more abnormal CSF biomarkers were actually much faster to fail that road test. And you can see the hazard ratios fairly high. The confidence intervals could be a little tighter, but with an N of, I think, about 120, to be expected, especially at that time, trying to get biomarkers in everyone. And so we were able to see this with CSF tau over A beta 42 and p tau over A beta 42. The most important thing, though, that I do want to communicate about this slide is that there was no difference in terms of their self-reported driving. So it's not as if they decreased their driving or increased their driving. There's no difference between the two groups. And there was no differences in terms of their CDR sum of boxes, so their MMSE scores, or a psychometric composite score. I think it was Trails A, Trails B, the SRT free, and then a verbal fluency measure. So what this study helped us to understand is that there is an important signal here with preclinical Alzheimer's disease and driving. There are changes occurring in function that precede the individual converting or progressing to symptomatic dementia. But as with any condition that you measure in, it's not really the lab, even though it's in the larger environment, it's still a controlled condition. You can have a ton of different biases. So Hawthorne effect, performance anxiety, and we really wanted to try to eliminate that. And so this will probably be about 7 years ago then, in 2015, I started looking around for, a solution to be able to track driving on a daily basis. And so at the time, Progressive was offering their snapshot device, and I tried that out for myself to see if I, number one, qualified for a discount and what kind of metric we can pull from it. I had 4 miles to drive from where I was living to the university, and I somehow didn't qualify, but they also jacked my rates up on top of that. So needless to say, I actually had to switch. But that monitoring of daily driving was something that stuck with me. And so what we did was we partnered with a commercial vendor to get data loggers that they typically give out to fleet companies like Coca-Cola, different departments in the United States, so Department of Defense. And so they track their vehicles, where they're going, look at speeds, look at crash risk. And so we thought, why can't we do this for our research study? And so we purchased about 20 data loggers, and we trialed it with a small n. So these devices plug into the OBD2 port, or the onboard diagnostic port in your vehicle. As long as the vehicle is made in 1996 or newer, it's required and mandated by the government to have this port. If you've got an electric vehicle, that's a whole different story, but I'm happy to chat about that at the end. And so as soon as you plug it in, it accesses the available satellites in the area and starts to transmit that information through cell phone towers to then storage in California, and then they package that and send it over to our research infrastructure and get to look at that on a daily basis. And so we've got publications on all of making sure that it was a valid and usable methodology. But here's sort of what we get. Every time the participant turns their key and starts the vehicle, we start getting data. And what we get are these little white circles are termed breadcrumbs because they represent, a little breadcrumb for a trip. And so within each of these little breadcrumbs, we get latitude, longitude, time, date, and the speed of the vehicle. But then we also get summary metrics over the course of a day. We get to look at how many trips were made, how many miles were made per trips, number of unique destinations, and if there are any specific thresholds that are hit, we're able to then get errors or at least adverse driving behaviors. So such as speeding, hard braking, sudden acceleration, and it's got an accelerometer built into it to detect impact. As simple as a little bumper kiss with either the curb or another vehicle to a full-on head, collision with a truck or, a light pole, whatever it might be. But more importantly, what we're able to look at is change over time, longitudinally. We're able to better understand driving behavior and establish really a fingerprint for our older adults as it relates to their driving. And so these are, again, some of these earlier studies. So the red star indicates their home location, and this is using ArcGIS. We're able to look at how far they're driving away from their home. And these are just 5 participants. And as you can see, for example, participant C, there's very little variation over the course of 5 months. But for E and A, there's significant heterogeneity there in terms of, or variance as they're making trips from month to month. And this just shows data from one participant over 5 months. What we're able to see is that most of her trips are made within about 10 miles of her home, or actually 5 miles, and very few within the 5 to 10 miles perimeter, and then only one trip outside of that 10-mile zone. And so you can start to sort of get an understanding that we can look at how far are they going from their home, where are they going, what are they engaging with their community, or how they're engaging with their community, and for how long, to better understand, really ecological movement and the interface with the environment. So we then really had to see, all right, can we potentially look this to model decline over time as a function of their preclinical Alzheimer's disease biomarkers that we're capturing? And this is one of the very first studies that we looked at. We had an N of 10 in each group, those that were positive and negative, and this was based on PET-PIB. Looking at amyloid within the brain. And so the great thing that we found was that there was nothing statistically significant between the groups, as you can imagine, with just an N of 10, but we did start to see some pretty discernible difference. We didn't, of course, reach statistical significance. And so we continued to follow that group for about 2.5 years, and then to see, is there a difference in terms of their driving behavior? And what we found was the dashed line here at the very top indicates those that are preclinical AD negative, while the solid black line indicates those that are positive. They have abnormal biomarkers. And what we're able to look at is there's actually a decline over time within these participants. And again, there's no differences in their cognitive tests, their performance over time. Nobody progressed to dementia. But we're able to see that there is some changes occurring, whether it's self-regulation or it's occurring at a conscious or subconscious level. We weren't really sure at that time. So we thought, okay, let's ramp this up and see whether or not we can predict, biomarker status, biomarker positivity versus negativity. And so what we did was we had, I want to say, about 100, a little bit more participants within our study. And so we looked at cerebrospinal fluid and also amyloid imaging. And we looked at those participants that had the highest 10% or the most abnormal biomarker level. And we looked to see, could driving itself alone predict preclinical AD, positive versus negative? And so they were dichotomized. And what we're able to show is the AUC wasn't terribly, it was exciting for, at that time, was 0.70, but, by now it's like, okay, not as interesting, but 0.2 when it came to and amyloid. When we added age into the mix, we saw that went up to about 0.8 across the models. And when we added the ApoE4 allele into the model, it went up to about 0.84. And then the neuropsych testing, so again, this is like the MoCA, verbal fluency, we're able to get about 0.9 across, close to 0.9 across the model. So that showed us that, okay, there's something here. Let's perhaps stick with this and continue on with following these older adults and tracking their driving. And what we saw was sort of this diminishing significance or the power when we looked at positivity across the top 25% that were biomarker positive, and then the median split. AUC went to about 0.8 across those three biomarkers, 0.8 to 0.85. So we're sort of cooking, but really not cooking with gas here. So a colleague in Canada really wanted to apply some machine learning algorithms to the data that we're capturing, and at that time we had recruited more participants and received, gotten more biomarkers. And so this was conducted in a sample of 139 older adults, 65 and older, and we had roughly about 64 of them that were termed to be preclinical AD positive, and another 75 to be negative. And we had a month's worth of data to look at how their driving changed over that 1 month. And the reason why, the 12 months. And the reason why we chose 12 months is to account for seasonality, because how you drive in the summer might be very different than how you drive in the winter. And so there were 4 random forest models that were trained to detect preclinical AD. And then each month for the participant was considered to be an independent time point. And so we chose the random forest classifier just because they outperform classical machine learning models in terms of their accuracy. They're a little bit more interpretable than the deep learning models. And so essentially what we found was that we were able to actually predict. So I'll point at least to this on the left-hand side. So driving alone was able to, for the AUC was 0.82. When we added age into the mix, it brought the AUC to 0.94. And the reason why this is really important is this is just driving, their natural everyday driving behavior, and their age. And this is something that you can get easily from any participant. When we added the ApoE4 allele into the mix, it only went up to about 0.96. And then there was really quite remarkable in terms of just being able to see the impact of function on predicting preclinical disease state. So this really allowed us to better, I think, validate the work that we've been doing and expand it a little bit more. So we're still on gear 4 if you're tracking along in the upper left-hand corner here, for those of you that drive manual or stick. So right now, what we're looking at is we want to do a head-to-head comparison across the conventional biomarkers. So amyloid imaging, cerebrospinal fluid, in addition to plasma. And these are some preliminary data showing the ability of our driving variables to be able to predict preclinical AD positive versus negative. And what we're able to show is that we're starting to see a pretty important signal, specifically with CSF. That seems to be our strongest biomarker in terms of statistical significance there. And the results really recapitulate our prior study with the random forest models. So I've been inundating you with biomarkers, but what I'd like to do is shift to talking a little bit about this in application and why I think this is really important for us to be able to use this kind of data to predict human behavior in terms of other conditions. So like most researchers across the country, our research came to a grinding halt during the pandemic, but we're still able to collect driving behavior. Participants didn't come in to get their annual evaluations, to get neuropsych, to get clinical evaluate or neurological exams and the rest of the battery. But because they had this chip still plugged into their vehicle, they went about their daily lives, of course, in adherence with their local ordinances on travel restrictions at that time. And so most of our participants reside in Missouri and a small percentage reside in Illinois. Illinois is only about 10 or 15 minutes away from our border. Most of them were retired, and about half of them, I think, had maybe one chronic hypertension, so fairly healthy overall sample. And what we were quite interested to see is, did driving differ pre-pandemic to pandemic? And no shocker, we were able to see that indeed, compared to this dashed blue line up here, which was data captured from 2019, when we're looking at 2020, and we use this index date of, I think, March 15th as this is when everything shut down, you see this precipitous drop here. And it really went on for about a month and a half or so, and this starts to be this little resurgence in terms of their driving behavior. But what we're all also able to look at is we're able to see where were they going and visiting during the pandemic compared to 2019. And so what you're able to see here, and I apologize, this is really small, kind of difficult, but these are all destinations that were derived from their end point. So that we indicated when they were starting from their home, and whatever that endpoint was, we took those latitude and longitudes and plugged it into OpenStreetMaps to get what whether it was a business, it was a church, whatever coding was given to that specific destination. And then we have that legend right over here. And what we found was akin to the first set of graphs that I showed. Again, there's a significant change and shift in terms of where they're visiting. But the one that was, I think, very important for a lot of participants was that they still went to see their doctor during the pandemic. Sort of makes sense, being an older population. They went to the grocery stores, that was priority, and they also went to the bank. But everything else in terms of other destinations they visited, that did decline due to the pandemic. And we also have another study where we showed the entire 2020 year compared to the prior years. So we were able to model pandemic behavior, which I think was really quite unique as a natural experiment, right? Life gives you lemons. Run with it and do some statistics and data analysis. So we wanted to then parse this out a little bit more and figure out what exactly is influencing human behavior when it comes to driving. And so this was something we really wanted to pursue because cognition is such a staple in terms of measurement in Alzheimer's disease and related dementia. And so in this study, we wanted to see if cognitive ability moderated changes in driving among our population. So what we did was looked at baseline cognitive performance on separate cognitive measures. So we had episodic memory, and these are all the tasks that went into that domain: attentional control, processing speed, and working memory. And these are all measures that are collected annually for our participant at our Alzheimer's disease related research center. And we looked at their performance on two driving composites. So we looked at driving space, which was termed to be number of trips, days traveled, unique destinations visited, but also adverse driving behaviors like overspeeding, hard braking, sudden acceleration. And so much like our prior work, we looked at linear mixed effects models adjusted for age, sex, education, the usual suspects, and follow-up time. And what we found was actually attentional control moderated the driving space variable. So drivers with low attentional control at baseline had significant decreases, more statistically significant decreases over time in their driving space. So, and I should have specified, so attentional control is the ability to monitor multiple different stimuli and to prioritize which one to pay attention to. And obviously with a task like driving, that's probably one of the prime cognitive substrates that we're using to ensure that we're being safe on the road and of course, not crashing. But interestingly enough, it was only driving space that the attentional control was significant for, not adverse driving behaviors like hard braking or sudden acceleration. But the other thing that I thought was really quite noteworthy about this study was that none of these other cognitive domains even came up on the radar as something that was statistically significant in our models, which is leading us to think that there's a lot more synergies that's occurring, and then your conventional paper and pencil measurements probably are not doing justice to trying to parse out a very complex task. And so while we were doing that study, we had another colleague of ours that does a lot of stuff, and he has data, and we share a number of these participants. Matter of fact, we shared about 96 participants. And what we looked at, we wanted to look at was, is there an association between driving decline, sleep quality, specifically obstructive sleep apnea, and preclinical Alzheimer's disease. We didn't get a chance to really parse that out, but I'll walk you through really quickly this study. So we looked to see whether or not the effects of obstructive sleep apnea and preclinical Alzheimer's disease status, whether that there was an interaction there that influenced driving behavior. So we looked at what we termed adverse driving behaviors like hard braking, sudden acceleration, speeding, which we know all increase crash risk. And then in terms of the sleep assessment, those were also done naturalistically within the home. So the participants had an Alice PDX, which is a sleep apnea test that monitors oxygen saturation, pulse rate which was measured by an oximeter, nasal pressure, airflow monitor, a thermometer, and thoracic and abdominal induction. And I'm going to butcher this word, but I think it's plethysmography. I don't do sleep research, but it was a ton of different measurements that were hooked up to the individuals to measure absolutely everything, to really the gold standard, which is a sleep study, which we also do. A minimum of 4 hours were required for each participant over the course of 7 nights within a week. Participants were also, they had to wear those. So they had to wear them for at least 4 hours a night in order to be included within the study. And so what we found was that if obstructive sleep apnea actually increased the likelihood of an older adult having more adverse driving events. And the odds was about 1.25 higher for those with lower levels of OSA. And so there was an interaction between age and the biomarker, where older participants in the biomarker positive group tend to have more adverse driving behaviors than those with lower levels of biomarkers. And so we're starting to see, again, this very complex overlap with preclinical Alzheimer's disease, other comorbid conditions influencing this functional activity. Oops. And so this study was just published, I want to say a couple of weeks ago. So we decided to dive a little bit deeper into the adverse driving behaviors as a function of biomarkers or preclinical AD biomarkers. And so we, again, use cerebrospinal fluid biomarkers here to parse out those who are negative and positive. And then, so we've got the positive group here and the negative group here. And we specifically looked at hard braking, sudden acceleration, and speeding. And what we found was that, again, those with preclinical Alzheimer's disease, they tend to have an increase in adverse driving behavior. So these riskier behaviors that increase the risk for crashing. But there was this really beautiful stepwise curve here, almost like a dose response curve. So to orient you to this, so the purple, which has 0.103 here, these on this end is those that are abnormal, so anormal, not abnormal. The red is abnormal. So as we're going down in terms of the saturation, you're going from abnormal to normal. And so all of these are negative. And we're starting to see that, again, this is over time, individuals that were more normal in terms of their biomarkers, they actually had a decrease in driving behavior. When we looked at the positive group, again, so this is right here in the middle, you start to see this switch from as the biomarker abnormality increased, there was an increase in adverse driving behaviors. And so these changes were not actually explained by self-regulation. We asked the participants, and we also had them self-report both a participant and a collateral source. And it's not as if they were changing their behavior. They weren't driving more, they weren't driving less. Their driving was fairly static, but there's an impact of the pathology on their ability to attend to tasks and to be able to navigate very safely. So all of that it's fun and interesting, but it really doesn't have an important, I think, role if we're not able to connect it with policy. And so another colleague of ours in neurology was really interested in looking at road diets. I was not aware what road diets were until she had to explain that to me, but Road diets are when they modify a road. So it sounds very simple, but there's a reduction in the number of vehicle lanes that are used for commuting. And it's most commonly converting a 4-lane road with 2 lanes that are going in the opposite direction into a 3-lane road. And it's typically you have a much larger medium and it's just 1 lane going back and forth. And in Missouri, we've actually had a natural experiment occurred where several of the major intersections in the county were converted, or at least stretches of road were converted and put on a diet. And then the reason why this is important to give a little bit of context is there's not a lot of practical implications when it comes to regulating driving behavior in the United States. We have 50 states that are all markedly different in terms of what one state will say for an individual that might be at risk for cognitive decline or a high risk for crashing. If we're thinking about the West Coast, so starting from Washington, Oregon to California, they have the most stringent regulations on how often an older adult comes in for getting their license renewed, getting a vision test, getting a road test, and then having to relinquish the keys. I'm not going to pick on the South, but that's the prime example right now. When if we were to go to the South, it's the Southeast, it's significantly more freer in terms of the restrictions. Where we are in Missouri, older drivers typically have to renew their license on a 3-year basis instead of, I think, the required 6 years. And so a lot of variability. So we wanted to look at, is there an influence of the road on driving behavior, and how is that impacted by preclinical Alzheimer's disease? And so 3 of the major road stretches that I included here in the figure to the right, what we have here is the crash count for that specific road stretch. And this was before the diet. And so Natural Bridge had about 419 crashes a year on average, Maryland about 27, and Pershing about 14. And after the road diet, you can start to see a significant shift here in terms of the crash reduction for individuals that are driving on that road. So we actually had about, I want to say 60 older adults that are in our study that you actually drove within these 3 areas here. And we wanted to see that their behavior changed before the road diet and after the road diet as a function of preclinical Alzheimer's disease. And I think we used cerebrospinal fluid again as that biomarker to look at pre and post. And so I believe we had about, I want to say 22 that were positive, and maybe another, and the remainder would have been negative. So what we found was, in terms of going with the initial road construction and the newer configurations, was that older drivers that were preclinical AD negative actually drove at much lower speeds compared to those that were preclinical AD negative. So those are, all right, I switched that. Those that were positive drove at lower speeds compared to those that were negative. And this was before the road diet. After the road diet, we actually saw that their speed was roughly the same. So the drivers that were quote unquote cognitively normal without preclinical AD had higher speeds, and everyone came down. And I think this is really quite important because it showed this overall speed reduction can lead to a reduction in crash risk and help to regulate the behavior. And conversely, we were expecting the converse with those that had preclinical AD to have a much higher speed and more risky behavior, especially based on our prior study. So we're currently preparing this right now for submission to a policy journal, but I think using this naturalistic data collection that we've really been collecting for the past 7 years, we're able to apply it in a number of different circumstances. And I think this is essentially where we're moving towards, is we want to better create crash metrics that will identify those, again, at risk. And so I mentioned in my very early slides that we were sampling those breadcrumbs at the 30-second level. Thanks to the rollout of the 5G network, we're now able to actually sample every time a person drives at the 1-second level. And then in terms of a crash from impact, we're able to get that in an extremely high resolution, which is about 200 hertz. So you can see here, as a crash occurs, which is again in milliseconds, the forces on the X, Y, and the Z, and then looking to see where is that resulting on the vehicle itself. But then with the latitude and the longitude that we also get with this data, we can start to better understand the environment that these crashes are occurring to see, is there environments that are more at risk for these types of crashes or navigation challenges? And how does this change for those that are cognitively normal, those that don't have preclinical AD, those that have preclinical AD, and those that actually progress to dementia? And I think this has enormous implications for not just structuring in terms of the roads and design, but also vehicles and what's really needed for the individual driver. So I promise I'm coming up to the end here because I'd like to save some time for some questions. So I threw this up here really because this is something that is counter to the way that most of us do science. You know, and if you're doing your PhD or you're doing your MD, you know, you focus on one specific process, one specific mechanism, and interrogate the heck out of it. But really what we've learned from this naturalistic work over the past 7 years is that the whole is actually greater than the sum of the parts. And we certainly saw that with that manuscript I presented, looking at the different cognitive domains and showing that, you know, it was only 1 out of the 4 that even had a remote relationship with changes in driving. And that quote is actually incorrect. That's really been attributed to Aristotle, but it's actually from his book of metaphysics. And this is what it says here. If you're interested, I'm a little philosophy nerd. So, but here's really where I think I see our work moving, because I'm always thinking about translation. And what I'd like to do is present you with a hypothetical healthcare and really a business model to screen our aging population. I was in a neurology seminar, I think last year, and one of the presenters indicated that for every 100,000 older adults in the United States, there's only 1 neurologist that's available to help them with their needs. And obviously, with the 88 million we'll have in about 30 years, there's just not enough to be able to support our aging population, particularly when we're thinking of neurodegenerative diseases. And so what we're hoping is that we can have these devices that are deployable in clinics across the country. And if a person is concerned with, either a family member or friend with their driving, you visit your clinician, they say, just plug this into your device, immediately gets, signal to be able to start detecting daily driving. We're able to run that through that data, curating it through the current pre-processing algorithms that we have, then work on some predictive modeling to better understand how are these potential conditions changing over time, but also visualize that data with not just the specific metrics that we're collecting in the clinic, but also the environmental metrics. Pulling in the AD exposome, understanding the impact of not just SES, but air pollution, climate, weather patterns. Certain areas that are better funded have better infrastructure compared to others, and then pulling all of that into this to really provide a crash risk algorithm and also a decline score. And then, of course, there would be consultation about that particular score with the entire team to say, does Mrs. Smith continue driving? Do we need more monitoring? Or do we stop driving? And then figure out what does a future without driving require? And how do we allow them to not just age in place, but to thrive in place? So I have a massive team behind me supporting this work outside of the funding, and I'm really beholden to a lot of folks, and this is just the tip of the iceberg. So thank you so much for your time and the invitation to be able to share a little bit of our research really over the past decade. I'd like to stop right now and take any questions and any comments that you might have.
Thank you so much. That was a really great presentation. Maybe I'll kick us off with a question and then see if others have some. So I'm kind of interested, what do you think of a comparison to younger drivers that are learning how to drive, and already they're limiting, some states are limiting how many people younger drivers can have their car and things like that. What do you think about a comparison to maybe a younger population?
Yeah, that's a great question, actually, Keith. So what we do know from the literature, so the worst drivers across all age groups are younger drivers. And the advent of social media and technology really hasn't helped to improve this, but there's higher crash rates across, I think I want to say it's like 16 to 25. And that's one of the reasons why when they have the ability to drive, your insurance premium goes up, especially if you've got kids within that age band, or adults, I should say. But right below that younger age band are older adults, but it's for really a different reason, because there's a confluence of specific factors that are influencing it. You've got declining vision, mobility problems, other chronic comorbid conditions that might be impacting their ability to use the vehicle. Perhaps the vehicle isn't appropriately set for them, right? There's the quintessential picture of Mrs. Smith sitting behind a steering wheel, can barely see above it to be able to navigate safely. And so car fit is a great way to be able to help fit the individual to their vehicle. And so it wouldn't be, I'd say, a fair comparison, right, to the younger population. However, there is a lot of emerging research that is coming out with younger populations, potentially, for those that have neurodevelopmental disorders that are able to drive and navigate safely. What does that look like? And do we need to potentially make smarter vehicles to be able to accommodate their needs?
Thank you.
So I have a question. You mentioned that there are a number of policies, state by state, that regulate older adults driving. What would you recommend to policymakers about how to regulate driving in older adults?
That is a billion-dollar question, and a loaded one too, because as a researcher, we're not very comfortable proposing these things, right? We need the data to be able to look and say, okay, this is what it's showing here. I think there are some fairly innocuous measures that we can take to safeguard and ensure, an older adult, as they are getting, into that point of where perhaps they need to have corrective vision, they need to have hearing aids, but they're not regularly seeing a practitioner, or perhaps they don't even have access to a practitioner depending on where they live. So I think the regulation could be that you require them to come in, every year to get your vision checked, hearing checked, to look at, whether or not they're recognizing the rules of the road, and not necessarily having to, do a road test. There are some states that do require, mandatory reporters. So here in Missouri, we don't have mandatory reporters. So let's say you come to see your mom's physician. You say, listen, Dr. Johnson, I'm really concerned with my mom's driving. She's had a number of near misses, and you live in a state that, he's a mandatory reporter. They would have to report that to the DMV, like Illinois. But for us here, it's very, very different. We don't really necessarily have to report them, but some folks do report them and say, okay, perhaps you need to, call this individual, and next time they're renewing their license, have them come in to make sure they're safe on the road. So I think low-hanging fruit, ensuring we sort of have those basic constraints, to be able to operate a vehicle safely, are there. The notion of cognitive status, dementia, or even cognitive impairment impacting one's ability to drive is really it's problematic for a number of reasons. We know that if you've got a CDR of 1 and sometimes even 2, you can still drive somewhat safely, because you're relying on driving as an overlearned task, right? You've done it time and time over again, but there's a tipping point where, the faculties no longer can compensate for the resulting pathology. And so there's that, decrease in the reserve that you have that finally lets up, and then you've got the increase in the crash risk. So I think, motor and sensory screenings are something that could be deployed. Cognitive is still on the fence, at least right now.
Thank you.
Yeah, it's a great question.
I guess I'll follow up with another question. To that point, I thought it was interesting in your slide for adverse driving and preclinical AD. Why do you think that you saw a decrease in risky driving behaviors over time, and then in the negative folks, if they were just doing their regular driving activities?
So there's a brilliant question, Keith, and it's actually a working hypothesis right now that I am looking on. So the way I'm thinking about, the preclinical stage of Alzheimer's disease is really as a function of cognitive reserve. And so as the pathology is kicking in, and the person perhaps hasn't really shifted into preclinical AD, decline is still occurring. And you're not having that, that robustness that you normally had. So, I mean, we're talking death of neurons, in the tens of millions and billions. And so my current prevailing hypothesis is that in the preclinical process, we're starting to see self-regulation occurring. And we know this with older drivers. So they typically won't go out in inclement weather. They won't go out during high traffic conditions or typically at night. So all of these things help to facilitate reducing crash risk and promoting, of course, safe driving. But I think as the individual progresses and converts, when I say convert, moves into preclinical AD positive, more abnormal biomarkers, we're starting to see the increase in these subtle signatures with adverse driving. And then as they progress into prodromal dementia or Alzheimer's disease, then you're starting to see a much more pronounced and a larger, crash risk or at least near misses. And so, again, I think it's on a spectrum, and we're just trying to really hone in and titrate what is the signal, and is this emblematic of many different groups. And so our goal now is to actually recruit a few other sites with greater diversity in terms of locations across the United States and Canada.
Interesting. Thank you.
Yeah.
I have a quick question.
Yeah, please.
Great talk, really a lot of fun stuff. I was wondering, where you set the cutoff, right, to make a recommendation, because I'm not sure I missed it, but you did not, did you assess crash risk, or do you actually observe crashes? Do you know, when, to what extent these changes in driving patterns really lead to crashes? It's always, so my background is economics, and we look at the cost of the two types of mistakes, right? You don't want to take away the keys of someone who can still drive safely, even though they have some cognitive impairment. At the same time, you do want to, take away those keys that where the risk outweighs the benefit. So exactly where do you draw the line, and then how do you allow people to appeal?
Yeah, so it is a very it's a big gray area, right? Because like you said, nobody wants to take away the keys, right? Because you're taking away the livelihood, and for a lot of Americans,
Exactly.
you depend on that. That is the focus of, a lot of not just social engagement, but also being able to complete their daily activities. And so that's really the next step in our research, is to look at those crashes. So there are a lot, believe it or not, there's a lot of near misses that we'll never get. But you have to cross again that threshold. And believe it or not, the crashes are quite rare for a lot of older adults. And if they do get into a crash, it's typically, something very minor, like a fender bender, or, not paying attention to something here. So, but because we're going to start to have this high fidelity data at the 1 second being collected, we're going to be able to start to detect those near misses. So those pre-events that haven't actually converted. And so then I think we'll start to say, okay, this is where all of this patterns for these individuals are contributing to. If when we do start to have more crash data coming in that are definitive, we'll be able to then look at this trajectory over time for each of those individuals. So we're there, but we're not quite there yet. But I think you're right. The economic implications are so critical for us. And it's, I forget, I think it's in the trillions for damages relating from motor vehicle crashes.
But if the risks are very low, the crash risk is still quite low, right? That becomes an issue. I think that would be interesting to see how that affects not just the older adult, him or herself, but also the other drivers on the road, right? So if they have to take evasive maneuvers to avoid that one erratic driver. That's a social cost that might not be captured in your driver data because you're not seeing how the other drivers on the road respond.
We will, if we get funded on our next R1 that I'm writing this month. So we're gonna actually put the, so we've got 2 sites in Canada and we'll have 2 sites here in the US. And in addition to the chip, we're actually gonna be putting cameras in their vehicle. And so we'll be able to actually, using AI, capture those near misses. So yes, invite me in about 5 years and we should hopefully have that data parsed out.
Congratulations.
Thank you, thank you. All right, I know we're at time, so I don't want to take up more time, but this was great. Thank you for having me. Anything else?
No, thank you so much for coming. I'll let Keith close it in a minute, but in the meantime, a quick plug for our career chat next week with Dr. Carl Hill, who's the Chief Diversity, Equity, and Inclusion Officer at Alzheimer's Association. It's going to be an informal conversation. We'd love to see all of you there. Keith, I'll turn it over to you.
Thank you, Ganesh, for such a great conversation and presentation. And everyone, please check out our website and follow us on Twitter. And we are hopeful to see you at the next seminar.
Thank you. Take care.
Bye. Thanks, Melinda.
Yep. Bye.